Hello, welcome to our lecture. The title of my presentation this evening is Introduction to NaProTechnology, Gynecological and Obstetrical Care. We have two audience viewers this evening, APP to APP virtual lectures, and also My Catholic Doctor. And I would like to extend a very warm welcome to the Christian Brothers Services. My name is Sharon Best. I am a physician assistant. I work in a small OBGYN office just outside of Philadelphia, and I'm also a My Catholic Doctor provider. About 95% of my practice is now NaProTechnology. I did create this lecture knowing that we have a broad audience, and therefore it will hopefully help some new NaPro providers, but also be informative to you if you have no medical background. There will be about 4 slides that will go into some clinical detail that would be directed more to the providers. So the objectives this evening are going to be, I'll explain to you what is NaProTechnology, as well as what is the Crichton model system. This is a method of charting a woman's menstrual cycle from which NaProTechnology evolved. We'll talk about the gynecological conditions that are treated with NaProTechnology. I'll introduce to you the biomarkers that are used to identify the root cause of the woman's symptoms. We'll talk a little bit about the diagnostic workup. We'll compare NaPro protocols to mainstream medicine guidelines, but I'll highlight the differences. So for instance, we have 6 luteal phase deficiencies that we diagnose in NaProTechnology and 5 ovulation disorders. I'll also explain to you what a laparoscopy looks like when it's done by a NaPro-trained OBGYN surgeon versus what a laparoscopy will look like when it's done by the OBGYN who has undergone the more typical residency and fellowship program. We'll talk just briefly about our treatments for infertility and recurrent pregnancy loss, and I'll compare protocols for NaPro to that of Assisted Reproductive Technology. IVF would be the one you're most familiar with. And we'll close the lecture with a little bit about teaching on authentic love. So what's NaProTechnology? NaProTechnology is the medical and surgical practice in which a provider, so a physician, nurse practitioner, or physician assistant, undergoes a very unique training program up at the St. Paul VI Institute in Omaha, Nebraska. We will learn to learn how to diagnose and interpret biomarkers of a woman's menstrual cycle in order to allow us to diagnose and treat many common gynecological problems. So NaProTechnology was created by Dr. Thomas Hilgers, who was a faculty at the Creighton University Medical School at the time. So he created a system of tracking a menstrual cycle where a woman will generate a chart that looks something like this. After receiving thousands of charts over several years, Dr. Hilgers realized that patterns were starting to emerge. So for instance, a menstrual cycle pattern that looks something like this can indicate infertility, whereas a menstrual cycle pattern that looks like this can indicate a pending miscarriage. So a little more about the history. So Dr. Hilgers created the Crichton model system in response to Pope Paul VI's encyclical Humanae Vitae, which can be translated on human life. This was released in 1968, largely in response to the FDA's approval of the first birth control pill, which was approved in 1960. Interestingly, in the 1950s, neither the US government nor any of the academic institutions, nor medical institutions, nor big pharma would have anything to do with funding research for oral contraception or for contraception of any type. It was actually the first birth control pill. The original research was funded exclusively by a laywoman named Catherine McCormick in partnership with Margaret Sanger. You may recognize Margaret Sanger as the founder of Planned Parenthood. You can easily find her early writings, and she was very openly an advocate of eugenics. She specifically had a desire and a goal to create a super race. She called them a race of thoroughbreds, by offering abortion, euthanasia, and sterilization to people who were of lesser worth in her eyes. And those people were poor, often African American, other minorities, and specifically also she felt that it would be advantageous for our society to rid themselves of the disabled. Now, what are some of the gynecological conditions that are treated with NaPro? Well, this slide has 3 conditions represented on it: polycystic ovary syndrome, endometriosis, and pelvic adhesions. And you can see the word infertility over here. Most of us in the NaPro world would probably agree that a very large portion of the patients that seek our help are suffering from infertility. Infertility can be either primary, which means the woman has been unable to achieve a first pregnancy, or secondary, which means she is having a problem achieving a second or third pregnancy. There's many reasons that cause infertility, and usually the cause is multifactorial. So some of the 3 of the very common causes that we see are polycystic ovary syndrome, endometriosis, and pelvic adhesions. And many women have more than one of these. So in order to describe these, I first want to describe normal healthy reproductive physiology, and I'll use this diagram. So this outline right here in tan is outlining your brain. So there's an area of the brain called the hypothalamus. When the woman hits puberty, the hypothalamus will synthesize and secrete a hormone called gonadotropin releasing hormone. That hormone will go directly to another structure in her brain called the pituitary gland and cause the subsequent release of something called follicle stimulating hormone. Hence its name, it tells you what it's doing. So follicle stimulating hormone is going to go to the woman's ovaries and begin to mature a few of her eggs. A woman is born with all the eggs she's ever going to have on day 1. So she in utero, she forms all the eggs she's ever going to have. And at puberty, she'll begin to develop a few. So these eggs, pictured in red, are developing within a fluid-filled follicle, pictured in yellow. Typically, one of the follicles will win out that we call the dominant follicle. This follicle is secreting a hormone called estrogen into the blood. As estrogen elevates, it feeds back to the pituitary and causes the release of luteinizing hormone, which will cause the rupture of that follicle. The egg will pop out, hopefully be drawn up into the fallopian tube, and if a sperm is around, conception can often occur right about here. That new life will migrate into the inside of the uterine cavity and implant itself into the uterine wall. The inside layer of the uterine wall is called the endometrium. Whereas back here in the ovary, once that egg pops out, the follicle changes and becomes a new structure called the corpus luteum. The corpus luteum is primarily responsible for secreting progesterone. The progesterone will go to the uterine cavity and it will cause that endometrium to become very nutritious so that it can sustain a new life. So estrogen has 2 target organs. One is the endometrium. It will make it nice and thick. And it will also target the cervix and cause the cervix to build up a very fertile cervical mucus. And that's what the woman is going to be documenting in the Crichton model system. Progesterone, as we mentioned, will then stabilize that endometrium from getting very thick and cause it to be nutritious and healthy for the baby. So let's talk a little bit about endometriosis. So we mentioned that inside layer of the uterine cavity is called the endometrium. It should be only within the uterine cavity. However, in this condition, little pieces of that endometrium get outside the uterine cavity and seed themselves elsewhere. We call these ectopic endometrial implants, and you can see them seated here outside. What we have in this area are ligaments. The ligaments will attach the structures to each other and anchor them to the pelvic sidewall. We have a bladder inferior to the uterus, and we have a lot of bowel, so a lot of your intestines is behind these reproductive organs. So these ectopic implants can seed themselves anywhere, in the ovaries, on the ligaments, on the bladder, on the bowel, and even just on the outside and even within the tubes. So we know that women with endometriosis have a very high rate of infertility. Now, pelvic adhesions, we can think of these as scar tissue within the abdominal pelvic cavity. So just like as if you had a laceration, if you fell and injured your arm or your knee, your skin is going to try to heal itself and oftentimes make a scar tissue. So the same will happen within the abdominal pelvic cavity. If ever the body perceives itself to be injured, it's going to try to cure itself and make scar tissue. So ectopic implants within the abdominal pelvic cavity, the body thinks these are injuries and will try to heal them. So women with endometriosis often have pelvic adhesions. The adhesions or scar tissue within this area look more like cobwebs, and they will grab onto one structure and attach it to another. So we can have adhesions pulling some of these reproductive organs to the side walls. We can have them completely distorting the normal anatomy, as you can see here. So we do know that even when you introduce any type of instrument, so for a laparoscopy, we put instruments into small incisions in the abdominal cavity and also a camera. So anytime you introduce any instruments or do any type of surgical procedures, the body is going to try to heal what it perceives as an insult. Even if a woman has had a C-section, the body will make adhesions. So adhesions are very common, and they will also contribute to infertility. So we treat pretty much any condition that is going to come into a GYN office. So we've discussed the first three. We also treat something called functional hypothalamic amenorrhea, which means that at that level of the hypothalamus, the gonadotropin releasing hormone, which is released in a pulsatile fashion, has been interrupted or completely stopped, and this woman completely loses her period and her fertility. This is seen very often with athletes. The etiology or the cause is that the woman is expending more energy than she's taking in with food. So she's exercising more than she's taking in calories. And this will shut down the reproductive system because the body wants to save her energy for the more vital organs like her heart and lungs and kidney. So we treat premenstrual syndrome, thyroid problems, abnormal uterine bleeding, the typical perimenopause and menopause symptoms, osteoporosis that often goes along with that. And also we do something special called progesterone support in pregnancy. So when a woman becomes pregnant, we will manage her pregnancy and try to keep that healthy by testing the levels of progesterone she has throughout this pregnancy up to 37 weeks, and we will give her supplements if she requires them. So this is the Queen of Hearts Fertility and NaProTechnology webpage that I've made up specifically to teach patients. So I use this website for all of my patients for every single NaPro visit that I have. I've also created it to help teach new NaPro providers. So please feel free to click into this website. You can email me at the end, or you can just Google Queen of Hearts Fertility and NaProTechnology. So let's talk a little bit more about the Crichton model system of menstrual charting. So as we mentioned, a woman is going to track her bleeding patterns and her cervical mucus patterns. So we have had about 30 years of research done at the St. Paul VI Institute that indicates that this method is effective in achieving a pregnancy in a normal, healthy individual by the 6th cycle 98% of the time. It's 96.8% effective in using this to avoid a pregnancy, again, with a serious need. That's in normal fertility. So it can be used with women with regular or irregular periods. And obviously it's safe and totally void of side effects. And we also know that we also teach, anyone who teaches this system has undergone a year-long training program in order to do that. And NaPro providers, as well as fertility care practitioners who are the instructors for this model, are all taught to promote chastity to the woman's state in life and to teach authentic love. Now we're going to look a little closer at the Crichton model system. So this is a larger image of a menstrual cycle. The woman will be taught very detailed information about how to document her bleeding patterns during her period, as well as her cervical mucus discharge. So here we have a standard period flow. She will be taught that if she's going to document very heavy on her chart, she should be changing her pad or tampon every 1 to 2 hours, and it should be just about full. If she's going to document heavy every 3 to 4 hours, moderate every 5 to 7. So we know that we have to look for a crescendo, decrescendo, or a decrescendo pattern in order to determine if this is a real period. So for instance, you can see we start at light, heavy, moderate, light, light. So we have a crescendo, decrescendo pattern here. We will be looking for something called breakthrough bleeds. Women who are having anovulatory cycles or cycles where they're not ovulating oftentimes think they're having periods, but they're breakthrough bleeds. And the breakthrough bleed will not have a pattern like this. It can look something like light, moderate, light, light and brown, light, moderate. So it won't have that classic pattern. We also are then going to have the woman recognize what we call her mucus cycle buildup. This represents that follicle enlarging that I showed you on the previous slide. So when the egg is maturing, it's going to mature in a fluid-filled follicle. That follicle is going to release estrogen and progesterone, but primarily estrogen. Estrogen is going to go to the cervix and cause this mucus buildup. So she will be taught in a very detailed and nuanced fashion how to document what she's seeing. So without belaboring this, we have something called the vaginal discharge recording system, and she will be taught all of this detail here. We'll just take a look at what's in yellow. So for instance, if she sees a mucus discharge that she can stretch up to 1/4 inch, she's going to document a 6. If that mucus stretches between 1/2 and 3/4 inch, she'll document an 8. And if more than an inch, she'll document a 10. And anytime she sees this type of mucus, she has to go over to this area and pick descriptors to go along with it. And this helps us to understand and see if that egg is developing properly. She will be taught to recognize something called a peak day. So the peak day is a day that's close to ovulation, but not necessarily her ovulation. So you can see here that we've done some research at the St. Paul VI Institute, and he has determined that 94.6% of patients will ovulate within P plus or minus 2 days. So if this is your peak day, you have 94.6% of the patients ovulating 2 days before or 2 days after, and 99.9% will ovulate 3 days before or 3 days after. So in a serious case, when a woman needs to avoid a pregnancy, she can have intercourse on the evening of the 4th day and know that she will not achieve. We also are going to measure something called the post-peak phase. The post-peak phase is going to start here on P+1, and it's going to end on the last day before her next period. So this woman has a post-peak phase of 10 days, which we know is a normal length. So let's talk a little bit more about biomarkers. So what is a biomarker? It's an objective sign indicating a normal or abnormal process. So we've talked a little bit about biomarkers that we're picking up on the chart, just slightly. We're going to talk more. But I want you to know that biomarkers encompasses things like any objective sign. So a vital sign is biomarkers, any of the laboratory tests, any of the imaging that we're doing. And again, we're going to look a little more closely at cycle length, post-peak phase length, bleeding patterns, etc. So biomarkers allow NaPro providers to predict with a very high degree of probability what's the underlying cause of the abnormality. So here's a nice slide. I put the biomarkers into 3 big categories in my head to help me remember. So you can think of them this way if you wish. So it's menstrual cycle and post-peak phase length abnormalities, bleeding abnormalities, and cervical mucus abnormalities. So in menstrual cycle and post-peak length, we know that if the whole menstrual cycle is too short or too long, we know that there's a problem. As well as if we know the length of the post-peak phase is too short or too long, we know that that's an abnormality as well. So a cycle greater than 38 days or less than 21 days is something that we will be looking at, and a post-peak phase greater than 16 or less than 8. So bleeding abnormalities. We've already mentioned a little bit about the menstrual cycle, what we're looking at there. We also look, and we mentioned too, the breakthrough bleeding. So if it does not have the typical pattern. So tail end brown bleeding is something else we look for. This means that at the tail end of her period, she's having some brown blood or brown spotting. Tail end brown bleeding greater than 2 days is considered abnormal. We'll look for premenstrual brown bleeding. So that would mean at this time in her cycle, she's seeing some brown spots. We know that if that's greater than 3 days, that's abnormal as well. And then we're going to look for intermenstrual bleeding, which is bleeding that occurs here in between. So for instance, women that have bleeding around their ovulation, little spotting, or bleeding when they have intercourse, that is a biomarker that we connect with endometriosis. So let's look at some cervical mucus abnormalities. So women can have what we call a limited mucus cycle. So we have a very interesting and complex way that our fertility care practitioners are taught to calculate a mucus cycle score. They do this by a number of different parameters they're looking at here in the mucus buildup. So if women have a low mucus cycle score, we know that that's one of the biomarkers that can cause that infertility, and we know how to treat that. Some women have a continuous mucus pattern. So that would be, this buildup would be greater than 8 days long. And we know that that can often indicate an underlying infection. So post-peak, peak type mucus. So women that are having mucus that looks like this in this area. And also something called frequent 2Ws. So when we get into these very nuanced areas, the frequent 2Ws and the sticky, tacky, and gummy mucus, these are so detailed and so nuanced, they can really only be ascertained with a Crichton model chart, really none of the others. So a frequent 2W, if it occurs after P+4, so this means the woman will have a no discharge that she can actually check for a stretchiness, but she will have a wet discharge and she will not feel lubrication. We teach the woman to sense if she's lubricative or non-lubricative when she's checking her mucus. So frequent 2Ws after P+4 can indicate a cervical infection, but more so, later data is telling us this can actually indicate chronic endometritis. Chronic endometritis is a low-lying infection that's in the uterine, that's in that endometrium. And we can treat that oftentimes to help the woman get pregnant. So a sticky, tacky, gummy mucus occurring on or before P-6 or on or after P-5 can also tell us an infection or cervical inflammation, which can be due to a few other things. So this is a slide that I'm going to just say is for your reference. So for any of the NaPro providers, I've gone into each of the biomarkers on the Crichton model system chart. I've given you the criteria for each and the significance that each of them means. So we have many different things that these can point to. So let's look at the NaPro diagnostic workup. So this is one of the slides that I'm going to go into a little more clinical detail for the providers. So we have mainstream medicine here, and we have NaProTechnology here. So we're going to look at them side by side. So NaProTechnology, as I mentioned, evolved from the Crichton model system, and you can see how detailed and nuanced it is. So mainstream medicine will often use fertility charting, but they can use many of the different apps, and oftentimes, as mentioned, they're not as detailed and they're not as standardized, so they will not give you as many biomarkers. So we both do labs on cycle day 3, and we've picked cycle day 3 so that we're very early in the menstrual cycle, so that the woman's ovaries are in what we call a quiescent state or a quiet state. So they're not beginning to build those follicles up yet. So looking here, FSH, most of us know that if this is greater than 15, this could indicate a premature ovarian failure, which used to be called premature menopause. Obviously, that can cause a woman to have infertility issues. Most of us know that if LH is greater than FSH, we call that a reversed ratio, and that can be a soft sign of polycystic ovary syndrome. When you add the estradiol, you can get a lot of information. So for instance, If a woman is in perimenopause, and oftentimes our women are trying to get pregnant when they're approaching 40s, because oftentimes women now are waiting much longer. So if you see that this FSH is elevated, LH may be normal or elevated, and estradiol is very elevated, that is an appearance or a pattern that occurs with an early perimenopause. However, if you see FSH is low, LH is low, and estradiol is low or undetectable, that's a confirmation that you're probably dealing with the functional hypothalamic amenorrhea, the one where that gonadotropin releasing pump has been either shut off or at least interrupted enough to cause her cycle to stop or to cause her to have very extended cycles, and they are often anovulatory. We both do prolactin, and we both do that fasting. NaPro asks a little more detail. They ask for no sex, no nipple stimulation, and no rigorous exercise for 48 hours prior to. And their reasoning for this is because any of this can stimulate the breast, and prolactin is increased with this type of stimulation. Now, I've added MJ here on the right. This is a little clinical pearl. It's anecdotal evidence that I have found that the use of marijuana can increase prolactin. So an increased prolactin can cause our patients to have infertility and abnormal periods. So I realized this because I had a few patients with high prolactin. I noticed that they were either using medical marijuana prescribed to them, or they were smoking marijuana. I asked them to stop, and they did, and the prolactin came right down into a normal level. I also had one patient who I explained this to, and she told me her endocrinologist, who she had recently been referred to by another NaPro doctor because of high prolactin, told her the same thing. So this is pretty good anecdotal evidence. So I would suggest that you check. I do check every patient. I ask if they're using any medical marijuana, if they're using any of the THC products over the counter. Many of my patients are self-medicating their anxiety with THC gummy bears or medical marijuana. We both do an androgen profile. We both do 17-OHP. So this is a lab that can help us diagnose another problem called non-classic congenital adrenal hyperplasia. This is a polycystic ovary syndrome mimic. We both do this. This lab must be done before 8 a.m. So a little pearl is most people know it has to be done before 8 a.m. because if you do it later in the day, it can be fictitiously low. But what I have also found out is if this lab is done later in the cycle, so for instance, the NaPro protocol suggests this to be done on P+7. However, I have noticed, and I have conferred with reproductive endocrinologist specialists, that when this lab is done closer to ovulation, it will be fictitiously high. And when we have this lab level at about 200, that's when we should be referring for a cortisol stimulation test. For that reason, I've moved this lab to cycle day 3. We both do androgen profiles. Ours is much more in-depth, and I've highlighted testosterone, free testosterone specifically, and DHEAS. Because if I have a patient that is cash pay or she can't afford this for some reason, I will minimize these labs and probably get all the information I need by doing just the free testosterone and the DHEAS. And the reason is because there's 2 types of polycystic ovary syndrome. Most of us know that that's why we're doing this androgen profile, to confirm the phenotype of PCOS or to confirm PCOS. There are 2 types of PCOS. One can be driven by the ovaries that will have the high free testosterone, and the other can be driven by the adrenal glands, which will have the high DHEAS. So you will probably catch it by doing these. A typical NaPro protocol is to do them all. A typical protocol for mainstream medicine is to just do the free testosterone, and if that is abnormal, they'll add additional tests. This one can miss the adrenal-driven PCOS. We both do thyroid panels. Again, the NaPro is going to be much more detailed compared to the mainstream med. Mainstream med is going to order just the TSH with a reflex free T4. we typically order a full panel, including TSH, free T4, T3, both total and free. Many NaPro providers order the reverse T3, and all of us pretty much order the anti-TPO antibodies and anti-TG antibodies. So on my website, I have a page called Thyroid Problems that explains all of these. I've chosen not to do the reverse T3 because I think sometimes I can cause more harm than good to my patients. So what I was seeing is that all the thyroid labs are very optimized. So for fertility, we all agree that TSH should be no higher than 2.5. The best optimization is between 1 and 2.5. So what I was noticing is I was noticing all of these thyroid labs on the panel would be optimized for the patient, with the exception of the reverse T3. So reverse T3, when that is high, it's indicative of increased cortisol release. We all release cortisol in response to stress, and it goes up and down throughout the day. So what I recognized is the reverse T3 has a half-life of only 30 minutes to 60 minutes, and therefore it's going to be very transient. You could probably check one single individual in the morning and later in the evening and have two totally different reverse T3s, depending on how stressed she's been, probably higher later in the day. So for that reason, I felt like I was doing more harm than good to my patients to tell them that they had a thyroid dysfunction because this reverse T3 was high. So I've completely omitted doing it. Now, anti-mullerian hormone. This is a hormone that is produced by the ovaries. We really both use it, probably for the same reason, to rule out a premature ovarian failure, which was called formerly premature menopause. There is some research being done to see if we can use this to ascertain polycystic ovary syndrome, but we really haven't gotten that we have levels that we know can indicate polycystic ovary syndrome. But many of us do have a soft criteria that if this is over 4, we're going to have a high suspicion of PCOS. The semen analysis is done on all of our infertility patients in both mainstream med and NaPro. Only we do ours with a special collection method that is morally acceptable, that I have a full slide on coming up. We both do hormone panels. Our panels will be peri-ovulatory, so we'll be doing estrogen levels just prior to ovulation, timed to the Crichton model chart, as well as right after ovulation. And then we're going to pick the peak estrogen level. We are going to also do post-peak panels. So we do a post-peak, so post-ovulatory. We do estrogen and progesterone, and we time them to the Crichton model chart again. Hormone panels are done in infertility clinics in mainstream med, but they're not standardized, and they're often not timed correctly because, again, the fertility charting that they're using is not standardized. So let's look at the semen analysis. So NaPro does this a little differently. In mainstream medicine, semen analyses are often collected by masturbation in the office. They're often given pornographic magazines to help them give that specimen. NaProTechnology uses a special way when we counsel all of our patients. So we ask them to avoid intercourse for 72 hours. We give them something called a semen collecting device, an SCD. It's really a condom, but it is a polyurethane condom that they can buy on Amazon that won't interfere with the semen analysis. So we tell them to put a few holes in the condom, have intercourse in the natural way, and because the condom has a hole in it, they will be open to the transmission of life. And then we have them take the semen that's collected in the semen collecting device or the condom and pour that into a sterile container that they're given by a company that we work with. We work generally with 2 companies. One is called Fellow and one is called ReproSource. And I have a nice webpage. It's entitled Semen Analysis that talks to you about exactly what we're looking for if you're a NaPro provider and exactly how to get in touch with these companies. The samples are transported to the lab in a timely fashion. The different labs have different ways. One lab has a designated carrier to pick up the semen specimen. The other lab has you mailing the specimen by FedEx. So let's talk about luteal phase deficiencies. So as mentioned, NaPro diagnoses 6 different types of luteal phase deficiencies. So this is another slide that's going to be directed to the clinicians. So type 1, what you want to look at here is what is in green. So I put in green, what are the sort of little pearls that I think I can help you with. Any of us can find these parameters in our NaPro protocol book. So on type 1, we have a post-peak phase that is less than 8 days, and progesterone is decreased all across the levels, usually P5, 7, 9, and 11 for sure, and P3 may be normal. Now, in a type 2 is the most common. This one, we have a normal post-peak phase, and then progesterone is again decreased all across the board. Type 1 and type 2 suggest there's an abnormal follicular development. So these patients we would expect to do well when we are going to give them ovulation induction with letrozole, say, or Clomid, because we know they're not developing the follicle well, and we know that these 2 medicines are going to develop a more robust follicle. So a type 3 is a little more interesting. This type, you're going to see a precipitous drop greater than 50% in P plus 9 or 11. I've seen this drop occur as early as P7. I recently had a patient who had a very high, so this first 2 progesterones on P plus 3 and 5 can be high or normal. Hers was quite high on P3 and 5, and then she dropped precipitously by 50% on P7, and then she dropped another 50% by P9. So she was extremely low on P9. Her progesterone was actually 4 at that time. So next, type 4 and 5 are a little more rare, and both of them need more studies. I generally focus on these 3. And the caveat here is that type 3 suggests the problem is not at the follicular level, but rather it is at the level of the endometrium. So we have an endometrial receptivity problem. So we want to be thinking of how to replace this progesterone, obviously as first-line treatment. And then we also want to be thinking about chronic endometritis, which is that low-level infection in the endometrium. We have ways of treating that empirically that may be able to help her succeed in getting pregnant. So now we're just going to look at a graph. So this was a study done at the Pope Paul VI Institute, published in 2004. There was 201 women in this. They were women who were suffering from infertility and recurrent pregnancy loss. And what you're seeing here is in the blue line, these are normal controls. In the red line, these are women with infertility and recurrent pregnancy loss. So this is the average of the women that they had in the study. And you can see that they were low on P plus 3, 5, 7, 9, and 11. So the point of this study drums home that many of these women with infertility and recurrent pregnancy loss have luteal phase deficiencies where they are low in the post-peak phase. So how does mainstream medicine think about luteal phase deficiencies? Interestingly, they have been coming around. So NaPro has been doing this for about 30 years. So this is a statement of the American Society of Reproductive Medicine. In 2015, they said there's no reproducible, pathophysiological, relevant, and clinically practical standard to diagnose a luteal phase deficiency to distinguish it from fertile or infertile. So they were completely saying this has no evidence. There's no studies to support this, because we practice in mainstream medicine, we practice evidence-based medicine. So we practice in response to what our research is showing us. We know that research can show anything. We know that because people skew their data all the time and they throw out their endpoints, etc. But a way to look at studies is if you see that there has been many studies done over many years, and you see that the participants' enrollments are very high, and you see that we're getting the same results over and over, we know that they're reputable studies. If you see a study that can only be produced here or there, and it has a very low number of patients, it's a very weak study. So we at least know we should still be looking at the research, and we should be evaluating robust versus very weak studies, and we should be considering. So interestingly, By 2021, the American Society of Reproductive Medicine changed their mind. And what they said is, although progesterone is important for the process of implantation and early embryonic development, luteal phase deficiencies has not been proven in an independent entity. So if you are a medical person, you can see there is a big difference from 2015 to 2021. So they have been doing research on this, and they're finding out that when progesterone is low, we do have an implantation problem. So that is a receptivity problem of the endometrial wall. I feel sure that in the next decade, they're going to be completely accepting of that, and probably more people will be getting progesterone replacement. So let's look at some imaging modalities. So we all do a pelvic ultrasound. NaPro specifies this would be done on day 5. I prefer day 5, I tell the patients. We're looking to see the ovaries in a quiet or quiescent state. Now we have something special in NaPro called the follicular ultrasound series. This is what allows us to diagnose ovulation disorders. So we are going to start on cycle day 5 to get a baseline ultrasound. And then we're going to ask that woman to estimate her P-6, so 6 days prior to her peak day, because she's been charting, so she can anticipate a peak day often. And we're going to have her go for an ultrasound. And then we're going to have the ultrasonographer measure the follicles as you see them developing. And when they acknowledge a dominant follicle, they identify one has reached 1.5 centimeters. Then we're going to have that patient go back every single day, and we're going to be repeating the ultrasound. So there's 6 ovulation disorders. So this is a busy slide. I've highlighted number 2 and number 6. And I've highlighted them because they are absolute infertility when we find these. So a luteinized unruptured follicle. So here's a picture of that ovary, and we have a few follicles forming. The dominant follicle is here. The egg ruptures, and then once it ruptures, this follicle becomes a corpus luteum, and this is a structure that's secreting progesterone. What happens with a luteinized unruptured follicle, hence its name, the follicle does not rupture, the egg stays within the follicle, but it becomes luteinized. You do see a rise in temperature, and you will see an LH monitor that's used. The LH monitor will tell this woman she ovulated. However, we can often tell that she may not have ovulated by using this follicular ultrasound series. That's the only way we can determine a luteinized unruptured follicle. We also are looking for afollicularism, which means that her follicle never even reached 1.5 centimeters. Both of these are absolute infertility. The other disorders that you see written here are relative infertility. So we may have a mature follicle, but it doesn't have an egg inside. And the reason this is relative is because sometimes this egg is just not seen on the ultrasound. We can have an immature follicle that never reaches 1.9 centimeters. And we know that this is a relative infertility. We can have what we call a partial rupture. Generally speaking, when this follicle ruptures and the egg comes out, we have a collapse of greater than 0.75 centimeters when this corpus luteum forms. When we have a collapse that's less that size, that's why we have the ultrasonographer measuring each day, we know that we have a partial rupture. We also have a delayed rupture. Typically speaking, this follicle should rupture, and it should do the full rupture and become more than 0.75 centimeters collapsed within 24 hours. If that takes 48 hours, we have what we call a delayed rupture. These two we really don't now know how to treat very well. We can make this follicle large by using ovulation induction. And here we can give something called a trigger shot to make that egg pop out. So laparoscopy. I love the NaPro laparoscopy because it's very different than mainstream medicine. We do something called a near contact approach. We use a high-powered camera, and we look for very small, tiny endometrial ectopic implants. Mainstream medicine has literature, and they feel that these small implants won't change the rate of pregnancy outcome. However, we can attest to the fact that removing those small implants certainly does. We do help our patients get pregnant when we find those little tiny implants using a high-powered camera and we remove them. We also have something called a near-adhesion-free technique, which is amazing. So I had mentioned that when we introduce instruments into the abdominal pelvic cavity, we create these adhesions or scar tissues. So when we create these adhesions or scar tissues, obviously we can make the woman even more infertile. So Dr. Hilgers has come up with a way to do a procedure, a laparoscopy procedure, so where we introduce cameras and instruments into her abdominal cavity to remove ectopic implants or to remove adhesions or to explore and see what's going on and what the problem is. So when we do this, we have a way to have almost no adhesions occur. And the way he does that is he closes all areas and he buries the sutures underneath, and we put graft over the organ. So here's some pictures. So this is a normal anatomy via a laparoscopy. This is the uterus you're looking at. This is the fallopian tubes. And here, buried here, is the ovary, here and here. So now what we're looking at is an ectopic implant that is outside on the uterine wall. Typically, mainstream medicine will take a laser and just burn this, and oftentimes that will come back. That ectopic implant will grow back and adhesions will come as well. What we do is we are going to get the entire base. We're going to remove all the very small implants. We're going to get to the base and we're going to extract that out. So what you see here is this is the uterus, this is the fallopian tube, this is the tube, ovaries tucked under here. But what I want you to look at is this area here. This is a divot created from pulling out that endometrial or excising that endometrial implant. We have another divot here and some here. Mainstream medicine will often leave some of these divots, the small ones, open because, correctly so, when we suture them, the sutures themselves will create adhesions. We know the divots will create adhesions. So what Dr. Hilgers teaches what NaPro surgeons are all trained to do in their fellowship is pull those sides together and bury the sutures underneath. So we use a non-adhesive suture. They're buried deep underneath. And then the organs are covered with this Gore-Tex graft. And we have an affectionate name that we use for this called pelvioplasty or plastic surgery of the pelvis. Let's talk now a little bit about a laparoscopy done specifically for polycystic ovary syndrome. NaPro surgeons are trained to do something called an ovarian wedge resection. This is not done in mainstream medicine. It was done from 1935 to around the 1960s, maybe early 70s. However, it went out of favor because there was many adhesions being developed after the surgery. But since we have the near-adhesion-free technique, NaPro surgeons are very comfortable doing it. So we do this bilateral ovarian wedge resection, where a wedge is taken out of the ovary. Polycystic ovaries will grow very large due to the woman is not ovulating, but rather she keeps accumulating follicles in her ovaries, and oftentimes they will grow large. So when we take a section out of this ovary, we can often return her to normal physiological state and help her to become more fertile. So what we found is when we do these bilateral ovarian wedge resections, here you see a pie-shaped section being removed from the ovary. So the patient's regular cycles will return often within 3 months. Polycystic ovary syndrome patients often have very long cycles, greater than 45 days or so. Patients will respond better to ovulation induction. So if we want to give them letrozole or Clomid, they'll also respond better to the progesterone replacement. It also reduces some of those androgens. A polycystic ovary syndrome woman will often have high androgens. As we mentioned, the high testosterone, if the PCOS is driven by the ovaries, and the high DHEAS if it's driven by the adrenals. So obviously an ovarian wedge resection won't do a whole lot to decrease the DHEAS. We improve the LH-FSH ratio, and we have a reduced risk, most importantly, of endometrial hyperplasia or cancer. So endometrial hyperplasia means that her endometrium is going to go very, very thick. And it does that because she's not ovulating. So this picture here is depicting something called ovarian drilling. This is done by mainstream medicine today. And the efficacy of ovarian drilling in returning a woman to ovulation and increasing pregnancy rates is really contradictory in the literature. It varies widely. So some studies say ovulation can be improved up to 30%, others say 90%. Some studies say pregnancy rates will increase 13%, others say 80%. It is used when the woman does not want to do IVF and other modalities are not helping. So some studies do indicate that if you do the ovarian drilling, the rates are actually, the rates in achieving a pregnancy are actually not much better than giving her letrozole. So why would you do a surgery? And obviously we're going to increase adhesions doing this surgery. And there's also some data to indicate that we decrease the amount of eggs that she has, so we make her a little less fertile all the way around. So why would we do this surgery when we know we're going to have adhesions form? And we really probably, the outcomes aren't much better than using ovulation induction, which is a term we use for giving the woman a medication called letrozole. So we're going to talk a little bit about that ovulation induction now. So ovulation induction is used in both NaPro surgeons and mainstream medicine and infertility. It's not considered an assisted reproductive technology. So it's when a pharmacological agent is used to stimulate ovulation in a woman who is not having ovulation, that's anovulation, or is having very few ovulatory cycles. Oligo is few. We use a medication called letrozole. It does quite well in maturing that follicle more robustly and giving the woman a chance to achieve a pregnancy. Now, I want to contrast that to something called ovulation stimulation, which is only used in assisted reproductive technology. The goal of this is to increase the number of follicles that the woman forms in that ovary in order to be able to extract those eggs for IVF. We have something called intrauterine insemination, which is when sperm is taken from the semen analysis given by the male, and it is directly introduced into the uterus of the woman surgically. This is usually timed to ovulation induction or ovulation stimulation. So it's not considered reproductive technology, but it would be considered not morally illicit for a devout Catholic. So assisted reproductive technology per se is when eggs are surgically removed from the woman's ovaries and they're combined with sperm in the laboratory and embryos are created. So these are babies created in the laboratory. They are either frozen for the woman's future use, or they can be placed into her body in order to try to create a pregnancy, or they can be donated to another woman. So a few examples of the more common artificial reproductive technologies that are used, but this is not a full list, is IVFET, which stands for In-Vitro Fertilization. So they have made the baby in the test tube or in the plate, and embryo transfer. So they are transferring the baby into the woman. Usually the embryo is transferred when it's about 2 to 4 weeks old. And we have frozen embryo transfer, obviously the woman's frozen eggs or the frozen embryos, and IVF plus donor. So the magnitude of IVF. First pregnancy ever in vitro fertilization was documented in 1976. Here's your citation for this information. The first live birth was an IVF baby, was in 1978. As of 2019, that's the latest data I could find, we had approximately 8 million IVF pregnancies reported worldwide. So there only was reported, so there's probably an underestimate. For the CDC's 2019 fertility clinic success rates, so this is specifically going to be the United States, we know that artificial reproductive technology has doubled over the last decade. We know that 2% of infants born annually are born by art. In 2019, there were about 330,000 reproductive cycles, artificial reproductive technology cycles performed in 448 reporting clinics in the US. We know this is a gross underestimate. And then you can look at the other stats, but they're staggering. What I think is really important to share with you is artificial reproductive technology's risk of birth defects and childhood cancers. There was a very interesting study published by Dr. Barbara Luke. She's from the University of Michigan, Department of Obstetrics and Gynecology and Biology. She published a paper entitled The Risks of Birth Defects and Childhood Cancer with Conception by Assisted Reproductive Technology. Here's the citation. Anybody interested in the paper, I'm happy to email it to you. So Dr. Luke and her colleagues looked at data from a registry called the Society of Assisted Reproductive Technology Clinic Outcomes Reporting System. She looked at that data for 14 years, from January of 2004 to December of 2017. And she looked at what was reported in the states of Massachusetts, North Carolina, Texas, and New York. So this is a robust, quality, good study. She had a sample 10-to-1 of normal pregnancies to those pregnancies achieved through assisted reproductive technology that she compared. And what she found was there was an increased risk of chromosomal and non-chromosomal birth defects, including defects in the cardiovascular system, GI system, musculoskeletal system, orofacial, so cleft palates they were finding, and also in males in the genitourinary system. So that's the male reproductive organs and urinary organs. There was also a significant risk of solid tumors and leukemias. So these are cancers. So this is staggering, and it's very important information that should be disseminated widely. So now let's look at NaPro teaching on authentic love. So I love being able to talk to my patients about chastity in the office. It's amazing because I have been disciplined and reprimanded over 20 years of my professional career for just mentioning God. Now I can mention God and chastity and talk about this. It's amazingly joyful and beautiful. So we do teach that contraception suppresses the normal healthy reproductive cycle. That's a medical fact. We know that. No one argues that. Mainstream medicine agrees with us. We do believe that when we suppress the woman's normal healthy menstrual cycle, we're putting a Band-Aid on her symptoms. We're not curing them at all. So NaPro takes our patients off birth control pills. We find out what's going on underneath and we fix the problem, which is amazing. But more importantly, there's a beautiful spiritual and emotional component. We believe that the sexual act of intercourse is very holy, and it's an act where men and women share most intimately, and this is shared with God in that He creates life. We believe the act is actually symbolic, so it's an outward physical sign, but what's going on underneath and not seen is much more important. And we do believe that authentic love between a man and a woman is both procreative and unitive. So it brings them together and it produces fruits, and the fruits are children. We teach that authentic love is selfless and sacrificial, and that it's a choice. It's not just a feeling. So we choose to stay with this spouse over time, and we choose to sacrifice for the other. And when we do that, we grow in virtue and we grow in love. I often recommend this book called Men, Women, and the Mystery of Love to my patients. Pope John Paul II released a document called Love and Responsibility. I believe it was around 1976. Edward Sri took that document and paraphrased it very simply. And the book is beautiful in relaying JP2's thoughts about authentic love and sexuality. I often say to my patients when they're in a relationship with whom they're not married, do you think this person would die for you? Sometimes they say yes, sometimes they say no. And I say to them, on authentic love, there is a man out there that will die for you. He will sacrifice his life and he will commit to you for the rest of his life. If you are with this man, you may miss the man that is meant for you. So I do encourage everyone to read this book. So in summary, NaProTechnology is a specialized niche of gynecological and obstetrical practice. We are specialized providers that we have undergone training to allow us to interpret biomarkers to help us make diagnoses and treat many underlying causes. NaPro workup is more detailed and nuanced. We draw hormone panels. We diagnose luteal phase deficiencies. We're very good at infertility and recurrent pregnancy loss. I've had a number of patients who have come to me after they failed IVF or some of the other treatments that we've discussed. We do a follicular ultrasound series to diagnose these ovulation disorders. Our laparoscopies are amazing. We use the near contact approach and the near-adhesion-free technique. We're effective in helping women to achieve a healthy pregnancy, and we protect the dignity of the woman and of the human person. And of course, we promote chastity and authentic love. So here are my references. Here's my email in case you wish to email me. I'm happy to take any questions and help you. So are there any questions now?